Please review the objectives when you're studying always to make sure that what you study covers those objectives. We have an older textbook and it's being replaced after you guys are done, so this lecture will be changing. But for right now, your textbook talks about autism spectrum disorders, and also it includes Asperger's, which Asperger's is no longer the approved terminology for some of these autism spectrum disorders. But remember, we're going to be testing on based on what's in the book. So for now, I've avoided putting anything that says autism in the test, but just so you know, follow the book for these questions. So you know, autism spectrum, about 12 to 16% of kids have this disorder. It's been going up rapidly in the last 15-20 years. And it's characterized by kids having impaired social interactions and impaired communication skills. They have repetitive sort of vocal patterns, but also physical movement patterns, restrictive interests, and restricted activities and behaviors. It's also more common in boys than girls, and the symptoms usually begin as early as 12 to 24 months. And the peak age of diagnosis is 8. With it starting at age 12 to 24 months, it could start sooner than that, but that's when people start to notice it most. So it starts with children not making eye contact, not liking to be hugged or held, which is unusual. The child will settle down when they're not touched. And so this can cause the parents, specifically the moms, to feel bad about their parenting and think that it has to do with them rather than being a sign of potential autism. And so they can just blow off the symptoms for a while, thinking that the child just doesn't like them. And then they'll suffer a lot of guilt when they find out that no, it actually was autism. And usually at 12 is when coincides when the time the child starts speaking, and so that kind of helps identify at 12 months, that's when the child should be starting to babble and make their first words, and by 24 months they should have be able to put 2-word sentences together. So that is often the first thing that brings them to the doctor. So it's not really known how children get autism or Asperger's, although there is a correlation. Kids that have fetal alcohol syndrome have a high incidence of autism. Fragile X syndrome and also PKU, they have high correlation with autism symptoms. There's also some theorized connections. So there's been a lot of good research out there saying that it might be a food allergy that the child has because of increased amounts of gluten. If the child has a difficulty breaking down certain kinds of nutrients, and then the symptoms show up at about 12 to 24 months because the levels of those nutrients are rising in the brain that aren't being digested. And that's why some parents are really strictly for having their child on special diet, especially a low gluten diet is common, but also no food dyes and low sugar, and definitely no aspartame and things of that nature. So there's no definitive proof of that connection yet. Some people attribute it to leaky gut syndrome, which gluten definitely contributes to leaky gut syndrome. Again, leaky gut syndrome isn't necessarily proven either, but if the parents believe in it, then I'm all for. It's not going to hurt the child to limit those nutrients, so I'm very supportive of following whatever diet the parents think works, and they will usually swear by it that they have better symptoms, lessened symptoms when they do follow that diet strictly. Other things to note, characteristics of kids, so there's a spectrum from very few symptoms to very severe symptoms. So some of the more severe symptoms you'll see are head banging, to the point where children might need helmets. They'll also bite themselves and self-harm. They may flap their hands like that, or definitely they'll have an aversion to being touched, loud noises, bright lights. They may have emotional lability, which that just is a fancy way of saying that they have irritability and tantrums more often than you would expect, and especially as they get older, it seems more like a tantrum associated with a toddler than with a child their age. So it starts to become more and more abnormal appearing. They also oftentimes have ritual behaviors that they have to do, and severe intellectual impairment. The ritual behaviors that I've seen personally in a family friend's child that has autism, he was obsessed with Thomas the Tank Engine. And so the ritual behaviors for him were that he wouldn't get up unless, he heard the Thomas the Tank Engine being played, the song. And he wouldn't eat unless he was given Thomas the Tank Engine plates and silverware to eat off of. And there were certain things he wouldn't do throughout the day unless he didn't get to see his Thomas the Tank Engine videos. And he wouldn't go to bed if he didn't have his Thomas the Tank Engine blankets and pillows. So if you take this example and carry this forward to how this child would be in the hospital, you would have to make sure that the parents brought in all of those special items so that the child could have the normal routine that they have at home. They're going to be more emotionally labile in any situation that's unfamiliar, and the hospital is definitely unfamiliar to them. And anything we can do to provide for them that would make it feel more like home is the best thing that we can do. So we would give them a room that's at the end of the hall, since they don't like loud noises. We would keep the lights dim for them, since they generally don't like bright lights, especially the kind of fluorescent lights that we have in the hospital setting. And then we would just work, if we could, keeping their room, if possible, separated from other kids, because it can be scary when other people see the child having emotional breakdowns in their behavior, and it can be scary, embarrassing for the family to have other parents around them, maybe feeling judged for not being able to control their child. Often people that aren't aware of what's going on have spot judgments that they make about the parenting ability. And then also, as nurses, if we have trouble dealing with that child, we always want to look to the parent, because the parent knows best how to deal with that child, generally because they've dealt with them for a long period of time already. Kids with autism spectrum disorders, as I said earlier, have delayed speech, and that's generally the first thing that parents notice. As I said, absence of babbling by 1 year of age, and absence of two-word phrases by 2 years of age. They also have echolalia, which is where they just repeat every word that they hear, which is something that kids do all the time when they're playing and trying to be annoying, but this child will do it continually. Also, you want to be sure to follow, if it's an undiagnosed condition, there are screening tools out there that we can use, that you can get on the internet, on a professional internet site, not a generally available to the public site. You would want to make sure you follow an evidence-based practice in using a screening tool. And then you would report that, if it's a new finding, to the provider, or recommend the family get the child assessed, because although we might think that they test positive for the screening tools, we can't make a diagnosis. So we would just make a referral. And the main therapies that we would want to do if the child's already been identified as having autism is review with the child social behaviors that will help them adapt to being in social situations better. They need learning therapies that are specialized and occupational therapies. The ultimate goal with these children is to help them prepare for as much independence as possible. A lot of kids with autism are mild and they can be fully independent and high functioning. Others are going to be so severe that they're never going to be able to be independent. But we want to start working with them as young as possible to get them to a place where they can be as independent as possible. Some kids will live in group homes where they have access to transportation and jobs, or some will continue to live with their parents for the duration of their parents' lives until other arrangements are made. You know, as parents grow old, I saw this in my family friend that we were close to. The parents loved their child very much, and they didn't want the child to go to a group home. However, they did have concerns about when they got too elderly to be able to take care of their child. And so they made arrangements to have the sibling, when they were old enough, take over care. And that was what worked best for them. But also, you know, some kids that are functioning enough, it's always good for them to have jobs, and there are certain jobs that they can be trained to do, and that can at least help them reach the highest level of achievement that they can for whatever their disability is. So nursing management is going to be about identifying the condition as early as possible, and that would mean that I would ask the mom or dad if they were presenting about if the child's making good eye contact, if they enjoy being held, if they're starting to babble. Those are the things that I would start asking about at age 1. Note behaviors such as lack of making facial expressions. That's another presentation that the parents might pick up on before the child even reaches 1, because before kids start to babble and talk, one way that we communicate with children is very young children, as we make faces at the child, and the child will generally mimic the face back, and that's just a normal behavior that most kids have and adults have when they're interacting with small children. So a child with autism often won't mimic the facial expressions at all, because it makes them feel uncomfortable to hold eye contact with somebody. So in the hospital, again, you want to make sure that you ask the parents about the child's normal routines and try to help provide any special items that they might need. Orient the child to the new setting as best as you can and limit noise. Provide any special diets that the parents might be having the child on, such as the gluten-free diet. And then when you're communicating with the child, it's good to use pictures and very short sentences. So the shorter the sentence, the better they're able to comprehend it, and they should be direct, so direct questions. Monitor their safety at all times, because especially if they're self-harming, then you would want to prevent those kind of injuries in the hospital. As far as your care plan goes, if you were the nurse, you would have a nursing care plan that included impaired verbal communication, impaired social interaction, caregiver role strain, and family coping. Those are some of the biggest ones. The next one we're going to talk about is ADD or ADHD, which affects about 11% of children, and it's more common in boys than girls. Some people question whether or not that's real. Some people feel that boys are overdiagnosed because of their boyish behaviors. So boys tend to be more rambunctious and active than girls. They need active learning and less passive learning. And so some people feel that boys get overdiagnosed. It could also be the children that are diagnosed with it do seem to have a correlation with lead exposure, mercury exposure, alcohol or tobacco exposure in the womb, preterm labor, impaired placenta, especially small placentas. There seems to be a correlation with that, and then certain genetic factors. Also, kids that have ADHD, some correlation has been seen with seizure activity. So some people have theorized that it's a form of a seizure or misfiring brain cells. It's also associated with stress. It has a higher incidence in families that are impoverished, have poor nutrition, or poor family dynamics. And there's lots of different neurological reasons that we could go into if you wanted to get more deep into that. It's a really fascinating thing to research. People with ADHD appear to have a deficit in catecholamines and dopamine and norepinephrine. Those things lower the threshold for stimulus. So what that means is that a smaller amount of stimulus that would make you feel overstimulated, their threshold is just lower. So they're overstimulated a lot easier, and that also contributes to boredom because it contributes to the amount of attention they can maintain on a particular task or something being learned. So manifestations of ADD or ADHD are decreased attention span and then a limited ability to self-regulate. Self-regulation is what we call it when, let's say normally you're driving in a car, right? And you're driving down the road and somebody cuts you off. Self-regulation is your ability to not scream and have road rage as opposed to somebody else. Or let's suppose you're in an argument with somebody or even just they're talking to you in a particular way that you don't like. Self-regulation would be your ability to just nod your head instead of responding in a way that's not good. But it goes even further than that, because self-regulation is also your ability to maybe when you're sitting in class, maybe all of you have this from time to time where you're bored, but you have to redirect yourself to listen. So self-regulation is part of your brain's ability that gives you the ability to tell yourself to redirect and listen. So some people theorize that that's really a muscle, that kids that lack it because they haven't exercised that muscle enough. That's one school of thought, and you have to remember in medicine, in areas like this, we often see that there's disagreement between different experts because other experts wouldn't agree with that. They would say that it's not a muscle, it has to do with the chemical balance in the brain. And so correction of the chemical balance is the only thing that will help. I feel like it's somewhere in the middle. I feel like there's some ways that we can learn to self-regulate better, that patients like this could learn to self-regulate better, and also the chemical balance needs to be treated. So we'll also see in patients like this fidgeting, impulsiveness, sleep disturbances, difficulty completing tasks, anxiety, mood swings, social withdrawal, and rejection. These things you'll see as the child gets to middle school and higher, because that's when they start to realize really get it that they're not the same as their peers, that they respond to things different, and they start to draw negative attention from their friends and from their teachers and parents and things. And so that causes them, since they don't know how to fix their own problem, that causes them to have shame and feeling multiple incidents of rejection from people, and that begins to take a toll on the child. Often kids are first referred by a teacher, and that's another reason that some people think it's more overdiagnosed in boys, because historically, and you can find the research to support this, that girls tend to have an easier time sitting at a desk learning passively than boys, and boys do much better with active learning. Well, in the classroom setting, it's passive learning, and also there's a self-reinforcing pattern that you have in school, where you have a teacher that has, if they have 30 students and they have to constantly take time out to redirect one student, that they may have self-reinforcing reasons that they would want to move that child into another class, and they will often make a referral for this. There's other things, other diagnoses that can be associated that look like ADD and ADHD but aren't. So for example, hyperthyroidism is an example of one where it could have similar symptoms and the child could be misdiagnosed. So it's important as nurses that we insist that all the proper things have been done to try and rule out medical condition first before going to this kind of diagnosis, so that kids get the proper treatment. And nurses are a big part of kind of asking the right questions to make that happen. So as far as treatment goes, the go-to treatment for a lot of times has been Ritalin, Adderall. Those are some of the more common names that people are used to hearing associated with ADD and ADHD. There are some important side effects you need to know, and this will definitely be testable. Anorexia is one, and what it is the children just lose their appetite, and so they'll tend to lose a lot of weight. There's also a potential of abuse of the drug because of this. So lots of kids hear from their peers that their friend lost 30 pounds because they got on Adderall and they want it too. Also, if you have ADHD and you don't need Adderall, it'll tend to keep you up a lot at night. It's similar to a methamphetamine, chemically similar. So a lot of times kids that have ADD or ADHD, they will sell their drugs to their friends. Or kids that don't have it will make a push to try to get on it with their doctors, or their pressure their parents to get the doctor to give them the medication. And it's well known that people use this in colleges sometimes to help with their studying ability. Unfortunately, because it's similar to meth, there are some serious side effects that occur with it that you wouldn't want if you don't actually have ADHD. There's a potential for becoming addicted, and the dose is very important to moderate. They should just have even if you do have ADHD, the dose should be moderated so that you don't have these extreme symptoms, which is sometimes the reason some people want the drug, is so they can have the extreme symptoms. Another thing I find is that students in my class, when I tell them this, they'll tell me that the doctor never told them this. There's a black box warning on these drugs because of a much higher risk of suicide risk associated with it. So it's lots of students come and tell me that no one ever told them that. So those are important considerations. That's not to say that kids that have ADHD shouldn't take the drug, because for the kids that need it, they really do need it, and it really does make their life more livable and help them, get through school and all their social interactions and all the things you need to do to regulate your life every day. So it's very necessary for them. Another thing is that, like I started to say, there's different schools of thought. So there's some providers feel that TV and video games make it worse. That not every expert might agree on that. So, but it's one nursing intervention that you could be aware of. Also, as I brought up earlier with the previous illness we just discussed, diet could be considered. So with ADHD, the diet that they also recommend is, again, low sugar, low processed food, no aspartame, and also they a lot of parents swear by limiting the yeast consumption. Also, vitamins are highly recommended. So omega-3s, iron, magnesium, zinc, melatonin, all of these things parents swear by that help their child, and there's some limited evidence on some of these vitamins. Echinacea, St. John's wort, and ginkgo biloba are also herbs that a lot of parents use and should be safe to use. Also, one of the things that has been found to be helpful in the right amounts, in moderation, is vigorous exercise. So if the child has hyperactivity, the theory is like get them out there and have them run it off, right? So it's a lot of parents swear by that. The risk you run is that whenever you recommend something to a family, there's always a risk that the family overdoes it, and there have been isolated cases of families running their kid to death. It's a very small incidence of that happening, but when you make these kind of recommendations, always make sure that you encourage parents to do interventions that are reasonable. So a reasonable amount of vigorous exercise is helpful to the sleep and to the focus and overall being able to settle down. Also promote self-esteem, because this is a difficult thing to have on the child's self-esteem when they get negative targeting, negative labeling, they're treated as different, and they have friends withdraw from them. It can really start to impact their self-esteem. Promote good sleep hygiene, and we've talked about sleep hygiene before, I think, in other classes. Sleep hygiene is just about having routines before bed, dimming the lights about an hour or two before bed, limiting TV or any blue screen, computer, video game, anything like that before bed, not eating within an hour or two before bed. Also, behavioral modification therapy. So it's also called BMT, behavioral modification. It basically uses Pavlovian kind of training to train the person to do or not do something that is an undesirable behavior. So it generally uses rewards for the correct behavior and removing rewards for incorrect behavior. So self-management skills are also something that these kids and adults that have this can benefit from, because there's tricks. For example, the little fidget spinners that kids have, those are pretty successful. There's other things that they have, YouTube videos where you study for, let's say, 10 minutes, and then you watch the video, and then you study for 10 minutes and watch the video, or different musics. So there's a lot of different types of treatments out there that are being helpful, and I'm sure as you know, the years go by, as you're a nurse, they'll get better and better at treatments that work. Other kinds of treatments or disabilities that we think about with kids are disabilities that interfere with the child's ability to concentrate in school or learn things. So learning disabilities that you probably already know about are dyslexia, and that impairs reading, writing, and spelling. But some other ones that you should be aware of, but I don't test on them that much, but you should know that they exist, are dyscalculia, which is an inability or feeling unable to work with numbers, dysgraphia, which is difficulty in reading, spelling, and composition, and dyspraxia, which is problems with coordination. So this also affects 5 to 10% of children, and the treatment would be enhancing the use of the abilities that they do have. One thing that all the kids need that have any of these kind of learning disabilities, including ADHD and even Downs or other kind of learning impairments, are the use of what's called an IEP, which is an individual education plan, and this is what the schools use to decide what what kind of accommodations they need. So for some kids, they need a separate room, or they need more time on a testing, or whatever it is, especially in, middle school, elementary, middle school, and high school. These would be very important to help them learn as much as they can, so that, they could still be college bound. And we have some students in college that have these IEPs that they have these plans in place to help them get through their courses. So we do make whatever accommodation we can according to that IEP. So as a nurse, what are your responsibilities? So your assessment should be focused on children meeting milestones for all of these. Milestones such as tying shoes, buttoning buttons, or hopping on one foot are typical kinds of assessments that we do in kindergarten. I can remember when I was in kindergarten, I still remember all the things, the tests that they had us do, and we had to be able to do those things to graduate kindergarten. And I'm sure that I would have still graduated kindergarten if I had failed one or two of them, but I might have been referred to a healthcare provider if I had failed any of these. And I remember clearly we had to do hopscotch, balance on a balance beam. You had to know your phone number and your address. You had to be able to cut with scissors, and also do the tying of shoes, buttoning of buttons, and things of that nature. So associate that with kindergarten. That's really the time when we want to make sure that the kids that need help get identified. We also want kids to be able to name objects, be able to show that they can read. In kindergarten, they really only know a couple letters, but by the second or third grade, they should be reading some simple reading books. We also want to make sure that they are fluent in their expressive speech. So how do they express themselves? A lot of times kids have major tantrums around that age because they can't express their words. So it's very important, because when you can express yourself, it cuts down on your tantrums. Tantrums come because of frustration at not being able to communicate, and also receptive speech. So we would assess for those kind of things. Fine and gross motor skills are part of the assessment that tells us if kids are falling behind in any of these areas, and then the ability to follow simple instructions to do something. And then intellectual disabilities is the next thing we need to talk about. So you can have an intellectual disability as a result of having something like Down syndrome or Fragile X syndrome or fetal alcohol syndrome, or you can have low intellectual abilities and the cause can be unknown. So this occurs in about 12 out of 1,000 kids. And generally it's related to errors in the DNA sequencing that impair the normal development of the central nervous system. And I brought up some of the common diagnoses, but just any kind of other problem that's unidentified. So for example, let's suppose a child has an undiagnosed space-occupying lesion. That could also lead to lower IQ. And until that's diagnosed, the diagnosis is unknown, so there would be an unknown reason for that. So they do sometimes want to look, if they don't know what the cause is, if they can identify a potential cause, like PKU would be another one. Defining characteristics. So intellectual disability is defined as having an IQ below 70 to 75. This number is important because when you're below 70, you're not able to, it's defined as not being able to do simple tasks, follow simple instructions, or basically your ability to function as an independent person. So it being lower than that foreshadows having difficulty taking care of yourself as an adult person. So this is something we would want to identify as early as possible, of course, to try and maximize that. And examples of things would be the inability to perform basic self-care, being able to do simple tasks around the house, such as like putting away dishes, social skills, academic skills, work, leisure, health, safety, any of those things. Those are all part of your IQ when they assess IQ. Some intellectual disabilities are also accompanied with sensory impairment or speech impairment, or motor disabilities. So for example, if you have Down syndrome, oftentimes your speech has a different speech pattern that's identifiable. Some kinds of intellectual disabilities are related to or caused by seizures. Some impair your ability to move your limbs. For example, cerebral palsy might be one. So be aware that some of these diagnoses go hand in hand. For Down syndrome, there's some physical findings that you would need to know for the test. And this is because if you see them and it's undiagnosed, you should make the referral based on these assessment findings. So with Down syndrome, you have a smaller head, flattened forehead, wide neck, it's around this area, slower set ears. So we measure generally the profile from the eye going back to the ear, and those with Down syndrome tend to have a lower ear. They also have, if you look at the hand, there's 3 lines across the hand. Those are called simian lines, and so a child that has Downs would be missing the middle one usually. So you look at the lines on the hands. Also, it's very common in kids with Down syndrome to have blindness or hearing loss. They have a higher incidence of diabetes, leukemia, and they also often have hypotonic muscles. So these are some of the signs that you could be tested on, so make sure you know those. And finally, sibling support. So I brought up the example of our family friend where the child had an obsession with Thomas. His sister agreed to take care of him, but she was much smaller than him. And in the beginning, when she was a younger child, they were constantly worried because he was much bigger than her and he didn't know his own strength or size. So injury to her was a big concern for the parents for a long time. And then as she got older and started to have friends, the friends maybe didn't want to play with her brother. So that promoted social isolation for her brother, but also the child, because she would be torn then between wanting to include her brother and not being able to include her brother, and then that causing her social isolation as her friends might withdraw from her. As she got older, a lot was expected of her to try and help support the parents taking care of the child. And especially in her teenage years, she was very good at taking care of her brother. And she started to realize and know at that point that the parents were not going to be able to take care of her brother forever. And she started to realize that if she was going to be married or have children, that there was a possibility that her brother would be coming to live with her at some point and needing permanent care. And so this was all things that she needed to come to grips with as she got older. And some people would say that that's a lot of responsibility to put on the sibling. And definitely they have to be willing to do that, and not all siblings would be willing to do what she did. So as the nurse, you want to constantly be assessing, what's the relationship with the sibling to the other child, and how are they coping with some of these issues as they come up as the child ages. So you would want to make referral for counseling if needed, and support groups for the child, the sibling, and also encourage open communication, because they may not feel that they have the right to say no. They're not going to take care of their sibling, or as more and more responsibilities get piled on them, they may not feel like they have the right to say no to anything, or to say that it's too much. So in our friend's case, the daughter had to make it clear that she wasn't going to care for her brother while she went to college, for example. And she felt like, and the family felt like it was fair for her to have that time and that opportunity to go to college and have a normal life and date and all those kind of things. But that required her to be able to talk to them openly about these concerns, and them to be able to hear her. So sometimes family counseling is needed to get involved to help a child navigate those kind of things. And as a nurse, you're advocating for the child that's disabled, but you're also always going to remember in pediatrics that the sibling is your patient and the family is your patient too. So you always want to try to help them all balance and have the best outcome that you can have for all of them. And that's my last slide for this presentation. Thank you for listening.